Good evening to all and welcome to this webinar on COVID-19, and especially the topic what we have selected is challenges in managing hospitals. And this has been organized by CAHO, Consortium of Accredited Healthcare Organization, which is a not-for-profit organization and working towards the improvement of quality and safety in patient care in this country. With the emergence of different accreditation system like NABH, NABL, we have seen hospitals and healthcare providers have become more conscious to improve their quality. So the objective of this CAHO is how we can take it in the next level, set benchmarks, and at the same time, we create a common platform to share best practices. So with this, I want to welcome all the panelists who are present here in this round table. And I begin with Mr. Parveen Pardeshi, who is the Municipal Commissioner of Municipal Corporation of Greater Mumbai, popularly known as MCGM. We have our special invitee, Mr. Suresh Lulla, the founder and managing director of Quimpro Foundation, Mumbai. We have Dr. Anupam Sibal, Group Medical Director and Senior Pediatric Gastroenterologist and Hepatologist, Apollo Hospitals Group. We have Dr. Vishnu Panigrahi, Chief Executive Officer of Kalinga Institute of Medical Sciences, Bhubaneswar. Air Marshal B. Keshav Rao, Group Head Medical Operations of Fortis Healthcare. Mr. Rupak Barua, Chief Executive Officer, AMRI Hospitals Group, Kolkata. Dr. Sandeep Bhudhiraja, the Group Medical Director and Senior Director, Institute of Internal Medicine, Max Healthcare. Dr. Vivek Desai, the founder and managing director of Hosmac India Private Limited. Then we have our own Dr. Vijay Agarwal, the president of CAHO, and Dr. Lallu Joseph, the quality manager of CMC Vellore and Secretary General of CAHO. So I welcome all of you, and it is really a great pleasure to have luminaries from the healthcare sector to be present here, and they are going to share their experience and they are going to give some of their practical knowledge and know-how in terms of managing the hospitals during this time of crisis. As we know, this COVID-19 cases have crossed 40,000 in this country, and Maharashtra is leading in terms of number, and at the same time Mumbai is at a very high risk. However, the ray of hope is, as on today, the recovery rate is around 27%, and hopefully with multiple intervention at different level, we can come out from this crisis soon. Without much introduction, I want to bring to all of you our first panelist and our special invitee for today's evening, Mr. Parveen Pardeshi, who I'm working closely with him for last 2 months and seeing in Mumbai how the sectors, whether it is private, public, and whether it is the BSP services, whether it is Book My Show, how different agencies have been brought together to see an improvement in this COVID management, and different strategies have been adopted time to time. Different kind of level of centers to provide COVID care has been developed. So I'll request Mr. Pardeshi to share with all of us the kind of approach has been taken by Mumbai Municipal Corporation with all of us.
So though we have the largest number of cases, what you should notice is that unlike any other state or even any city, the total number of cases, the tests that we have done is amongst the highest in the country. So today, if you see, Mumbai has done 7,191 per million. The nearest is a state, a whole province, which is Tamil Nadu, with a population 4 times our size. and they are still half a thing, that is per million. And Delhi is just 1/7 of us. And Kerala, which I'm never understanding how Kerala can claim that it has flattened the curve when they have done only 32,000 tests. Because if you see this graph, it's just statistics. The more you test, the more you find them. As you can see, today we have reached something like 93,000 tests, and every day we are able to see some amount of new cases. So my first issue is that we need to test, because that is the most aggressive way by which we can identify who the positives are, and therefore then contact trace their contacts and isolate and quarantine them, number one. Number two, how did we enhance this testing capacity? Again, as Dr. Joy Chakraborty was saying, by public-private partnership. While we expanded the testing capacity of our own labs, that's still limited. So we made a network of all the private labs. Mr. Joy Chakraborty knows, and all the private labs, we facilitated their permission with ICMR. We wrote multiple letters, got their applications persuaded. I personally spoke to Dr. Bhargava, and therefore now today almost every single private lab is ICMR enabled to test for COVID, and therefore we could double these things. And the strategy that ICMR accredited labs are following is in sync with our strategy. They don't test randomly. Whoever contacts we have traced, whoever fever clinics we have taken, they test them, so that we have a concentrated strategy to search out where the positive cases are. The other thing which you all medical people need to help us is that asymptomatic cases are roughly 50%. There are symptomatic mildly 23%. The really difficult cases are these critical 2 to 3%, and this is the one that we are finding sometimes difficult to handle because of very large number of pressure on our ICU beds. But the death rate now has come down to below 4%, it's around 3.7%. The way we are identifying people is we are doing fever clinics. So we have screened about 11,000 people in the last 2 weeks, which are near containment areas, and we have found roughly 238 positive cases from them. We are also doing the X-ray surveillance because PCR tests take time. So we have set up digital X-ray clinics at most of our hospitals. Hinduja also has them, HBT has, Poddar has, Kokilaben has, Kasturba has, and this is able to give, by connecting to large data, AI systems, almost a very correct guess whether the person is likely to have COVID or not by looking at the chest X-ray. The other thing that we have been doing, which is new, is searching for elderly people with comorbidities, because that's the major source of our mortality. So irrespective of waiting for the COVID symptoms, we are directly looking for people in the slums who have high blood pressure and high diabetes, which is mostly not managed. We are using ASHA workers, NSS, NYK, and then we are trying to bring them for the normal treatment, because these are the people who are catching this infection and dying, which we are not able to reduce mortality. My next issue is about contact tracing, because that is the biggest safety factor. So if you can see, for 8,000 patients, we have been able to trace 190,000 contacts. And we are following a new strategy in Mumbai, because though home quarantine is permitted, we are now forcing lots of people to go into institutional quarantine because they live in slums. And as you know, in slums, one room quarantine is no business. So 9,700 of such people we have brought out in institutional quarantine. And we also test these people, and 1,647 of these people have been tested positive, which we again isolate. The other strategy is for containment zones. So now you can see Mumbai has large number of buildings, 784 buildings where cases have been noticed who are in containment zone where we don't allow people to go out. And these red zones are the ones which are in slum areas. So these slum areas also not fully put in containment zone, but we are narrowly defining them in areas where we find a large number of cases. For example, entire Dharavi is not a containment zone. only a population of roughly 1.5 lakhs of its 8 lakhs is in a very tight containment zone, and that's why we are seeing cases confined to that area. In the general fever clinics around Dharavi, we are not seeing cases because of this strong containment zone. The same process we did for Varli Kolivada. I just give an example of Dharavi because Dharavi had a huge issue. So today we have around 214 cases, and we are able to keep the people confined by ensuring that we provide grocery packets, and we have been able to screen citizens with fever out there, more than 47,000 citizens, and 1.25 lakhs is the population which is of the total Dharavi, which is in the containment zone. Here are some pictures of fever clinics and the desanitation. Now, this mortality rate is a very big worrying factor for us, and that's something which we are really struggling with. One is, of course, because of our younger population, our mortality rate is also occurring in the 41 to 50 group, which is very scary because people were always saying that the mortality is between 50 and 60. So this is one thing very scary. The second thing is, of course, 75% have pre-existing diabetes, hypertension, heart disease, and these are mostly not checked. So unlike people in middle class families who look after their parents or etc., I know for their diabetes, hypertension, we don't realize this, that in slums also lots of people have this, but they live with these problems. And then when they catch an infection, that becomes fatal. So now only we are discovering such people and trying to see if we can treat them before COVID hits them. The other interesting thing about Mumbai, and I think it's true for some parts of the other world is also, that if you see the average death rate recorded in Mumbai in 2017, in let's say January, that was around 8,211 for 3 years, 2017, 18, 19, and 2020 was also on the same. In February also, it was the same, whatever was the average of 7,420. In 2020, February is also same. But you look at when COVID comes and the lockdown comes. In March, the 3-year average of the previous 3 years is 7,467. But in March 2020, it is less. It's less by almost 1,000. So there is a reduction of 24%. And the same is followed in April. I will just be giving the April figures also. In April also, April 2020 is substantially less than the month of. So this reduced mortality is not fully explained by the fall in accidents, etc. So it's explained by the fact that if you see the deaths from hypertension, heart attacks, diabetes, pneumonia, all of these from 2017 to 19 were between 700 to 937. But in 2020, it's 595. So while there is a reduction of 36% in these normal deaths, that 36% has been captured by the COVID deaths. So therefore, there is also a classification problem. If you remember some of the doctors from California, that a lot of us are being forced to call people with COVID deaths, though they could have been non-COVID deaths. 75% of our deaths are to severe comorbidities in an uncontrolled manner. And this is completely explained by these statistics, that there is no way in which in 2020, the deaths from these hypertension, heart attack, diabetes, pneumonia in municipal hospitals would be less by such a huge number. So that's one thing that we need to analyze. The second issue is that coming late. So lots of people are being brought dead or coming late within the first 2 days. So there's again a need to search out such patients in slum areas and bring them early. Of course, our fewer clinics are helping us, but that's not enough. These are the sorts of step-up planning that we are doing. If we expect 75,000, which is some projection of cases by end of May, then we are trying to make up beds for 12,000 positive cases and 63,000 asymptomatic, which we are doing school rooms, etc., to trace them. On the way forward, I have talked a lot about asking the economic stakeholders not to do any layoffs of staff. And also we can have younger people going to offices, maintaining social distance, while the older people with comorbidities stay at home. So this sort of a process can be followed as we slowly begin. Municipal corporation has a budget of $2 billion for infrastructure. So that's something which we are willing to spend. You might see that even as Mumbai is under lockdown, almost all the roads, the coastal road, the Suresh lines, all the works, I am continuing them because we have to do restart the economic engine, and the infrastructure is one of the key things. Of course, we have to follow very careful. Fortunately, most of these works are very mechanized, so we can afford to work on them. So this is my small presentation. I hope that if there are any questions, we could go ahead.
Thank you very much, Mr. Pardeshi. And I'll request the viewers to post their question in the Q&A box, and from there we can pick up. But before taking those questions, I move on to the first panelist, Dr. Sandeep Bhudhiraja. Basically, if you see that he has presented an overall public health strategy for Mumbai, and a significant part of that has come from the clinical delivery sectors, that is the hospital, that how that is getting managed, including artificial intelligence, including analysis of mortality in the hospital. So when that is the key, that how do you stop and prevent mortality, how you give treatment and you may cure your patients who are coming for the COVID-19 treatment, it becomes very important to have a setup of clinical protocols. And as because private sectors as well as governments, most of them are working in isolation, it becomes very difficult to have a set of protocol in place which can be followed and practiced by across other hospitals. So to my question to you, that how do you finalize your clinical protocols in this challenging time, and keeping in mind that your mortality rates are less and quality of life improves when patient comes to your hospital?
Thank you. So I'll start with actually something which is very positive, which we have seen these unprecedented times, is that there has been an extremely positive response of the clinicians, of the entire fraternity in adapting to the new policies and protocols. In fact, the things have happened so fast, and the adoption has been at an equally amazing rate. So I think that gap from the intent to action this time has been extremely fast. And the other very interesting thing we are seeing is a very good and a positive and total alignment between various cadres in the healthcare professionals and between the public and private agencies. So that's something which is to start a positive note. And of course, what all of us are suffering from is a lot of uncertainty, definitely a common anxiety also. Now, as we all know that there is no proven treatment as yet for COVID, and new evidence is coming up almost on a daily basis. And many times the evidence we get is anecdotal. What we have been seeing is we start in one direction and suddenly we have to change that direction. And this happens on a regular basis, whether that's from the medical content perspective or whether that's from a regulatory perspective. Things keep changing very fast, and one as an organization has to adapt to it. In fact, I would say never before have we been faced with a situation where such fast and swift decisions have to be taken, and sometimes you work like a pendulum and swaying from one direction to the other. So how we choose protocols and essentially make such protocols, which sometimes even never existed, would depend upon variety of factors, depending upon whether yours is a COVID standalone, non-COVID hospital, what is the latest clinical evidence to support what you are wanting to do, what are the various clinical trials, and sometimes these trials could be very, very small trials, which may or may not really stand the test of time over a period. What stage of lockdown a particular city or state is in, and then also at the same time preparing for a post-COVID scenario. And then trying to balance between the various guidelines, whether that's Ministry of Health and Family Welfare guidelines, the ICMR guidelines, which come from various clinical associations, international organizations like WHO, CDC. There's too much of an information overflow. And one sometimes trying to do a balance to, you may get attracted to a particular guidelines which has been practiced in US hospital, but to our Indian context, that's not really look out well. So I think these are just the overall context or basis of which we at an organization Max set to create a guidelines protocol. And as I said, because it changes very fast, so we have come up with a of guidelines, and we have almost come to a fourth version over just last 6. But you can understand almost every 7 to 10 days, the set of guidelines, the complete compendium changes. Started off by creating a central task force, which would basically constitute of people like clinical medical director, superintendent, and the quality managers, set up a war-like room where almost regular daily group meetings or calls would help, set up a hotline or a 24 hours helpline where all the internal stakeholders could reach out. We got together a set of clinical experts or specialists who could give both science and collate evidence for us from various ministries and other ICMRs and other societies, and especially put protocols in place like telephonic consultations and specific guidelines regarding modalities like oncology, dental, ophthalmology. Those are very critical areas where one may not put focus on, but actually the protocols would be very unique and very specific. Surgeries, for example, endoscopies. We looked at other aspects of COVID and non-COVID situation, like the infection control practices, the environmental issues, the consent which goes into all these things, created and uploaded these folders on all our hospitals through the desktops. So anybody, any doctor, any healthcare worker can actually at the click of button access these guidelines. We in fact have shared all our guidelines in various platforms for everybody to use, critique, or add to that. And most interestingly, what just not created these guidelines, but equally created a set of audit points or audit criteria, so that the clinical teams, we have labeled them as health or welfare teams, which would go around the hospitals doing an audit checklist as per those. Where we see the controversial issues or the challenges are as follows. Availability of certain drugs. Now, although they may be part of the protocols, but certain drugs we all know of are presently not available in our country. Remdesivir is one example. Favipiravir is now coming in form of trials. Plasma, convalescent plasma, we all know of. So that brings us to a very interesting point of conducting clinical trials during this time of pandemic. At Max Healthcare, we presently are almost running 17 trials, clinical trials in context to COVID, including use of plasma, convalescent plasma through the DCGI, and we are enrolling into the favipiravir trial also, other than large epidemiological studies, use of HCQS in prophylaxis. 2-3 areas where really one looks for right answers is the appropriate use of diagnostic testing in non-COVID patients, the preoperative patients, role of COVID testing in healthcare, quarantining. So whom to quarantine, when to quarantine, what's the adequate quarantining protocols? Now, all of us have designed our protocols. We have taken guidance from ICMR guidelines, but those sometimes I see as becoming big challenge. Admission and discharge criteria, and now the recent guidelines where the mild or pre-symptomatic cases can be isolated. How does our health, how do our organizations work closely with the nodal we do in terms of licensing for patient management at home? So these are those regulatory stuff which even the government periodically keeps updating and changing, and we have to keep abreast with all those issues. So I think these are certain areas of brief I would have spoken about as to how we set about the protocols in place and the challenges we are presently facing.
Thank you, Dr. Sandeep, and I will come back to you with some specific question. Before I move on to Dr. Anupam Sibal, I have a couple of questions which have come for Mr. Pardeshi, and I have several questions. Out of that, I'll take only a couple of those, and I'll be asking him to respond to that. The first question is, how effective is your X-ray testing? So the person who has posted, he wants to know the X-ray testing which has been shown in the presentation, how effectively it is working. Over to Mr. Pardeshi. Your speaker is...
Sorry, I had this thing. Yeah, could you just repeat, please? Sorry.
The question is, how effective is your X-ray testing? What you have claimed?
That is very effective as long as it can be tied with large data. For example, we have Fractal and Curer. There are 2 or 3 companies which have done a large data analytics which compare the type of images. So sometimes, for example, the question came that if the COVID has not progressed very much, then probably you can't find it. So they said no, even then they can search for COVID signs at some ages. I'm not again a radiologist, but Dr. Lakdawala and various others are pretty confident that they are able to 70 to 80% before taking a PCR test, they are able to say that yes, he's likely to be COVID or not COVID, which is very helpful for us for triaging basically. I mean, we still need to do the gold standard test, but RT-PCR. But before that, if at least we can get patients from the hospitals who are coming to hospitals or in the community, identified that these are most likely to be COVID positive and then treat them as such, we can separate the non-COVID positive to go to normal hospitals.
And I'll take one more question out of the whole list. That your question, the question is that you mentioned mortality rate has decreased in March as people are quarantined. Is it the reason that why the mortality rate has reduced by 24% in March 2020?
So I don't think that that is the only reason. It is better care and slightly ability for heavy testing, ability to get patients a little bit earlier, and a large number of people coming from fewer clinics who are pre-identified at early stages rather than when they come rushing at the last stage. But I think we are hitting up a very big wall of ICUs now, because some of the patients who are coming late, we are not able to save them because we are very short of ICU capacity. So that's something which we have to work on, how to expand it at a short duration.
Thank you, Mr. Pardeshi. I move on to Dr. Anupam Sibal, and as he comes from Apollo groups of hospitals and geographically located in multiple cities in this country, they have also tried to standardize and create their own benchmark in terms of delivering care for the COVID patients. So my question to Dr. Sibal is, can you give an overview of the challenges, what you had already, and what is your plan in the future to overcome that?
Thank you very much to the entire team at CAHO for organizing this webinar, and to all the participants. I love the presentation from Mumbai. It was really very helpful to understand how proactive the government has been and the amazing work that has been done. And thank you, Sandeep, for providing an overview of the excellent work that you've done at Max. You know, some of us had read that beautiful book, Love in the Time of Cholera, by Nobel Prize winning author Gabriel Garcia Marquez. Who would have thought that we're going to have to talk about, redefine practicing medicine, running hospitals in the time of COVID-19? Actually, our lives have just turned upside down. On one side, we have to care for patients that we've been caring for decades, managing their needs, answering their concerns, lots of apprehensions there. And on the other side, preparing for this COVID battle, getting our hospitals ready, our clinics ready, our network ready. Working with the teams, motivating them, whether it's the housekeeping staff to the nurses, and also the young doctors, you know, who have to spend 6 hours in PPEs without food and water, without bio breaks. So it's been really challenging to balance the two. And for us, it's a little more complicated because we have 73 hospitals in 16 states. So which means 16 different government rules, because health is a state subject. So in one particular state, you can't admit anyone with COVID. In another state, you can test if your lab is approved by ICMR, but you can only test as an inpatient. In certain states, you cannot test at all, whether you're accredited or not. In certain, you can not do home visits to collect samples. So for us, it's been a daily exercise through the COVID command center. Hey, what is new today? Let's put it all together, and we have a central repository now, which is so huge of what every state has said, and there have been so many changes, and you know, it's expected that there will be changes as this is a very dynamic situation. But for us, 16 states, 16 different sets of rules, and many of those guidelines change. And on the other side, you have the central guidelines, you know, what the ministry is saying, what NCDC is saying, what ICMR is saying, what PCGI is saying. So for us, you know, keeping abreast of what the developments are to make sure that we are in full compliance and keeping with what is expected of us has been a challenge. I think the clinicians have been phenomenal, whether it's managing COVID or managing other conditions. And while we've been in lockdown, we have some really touching stories of how, cardiac interventions, neuro interventions, oncosurgery, we've in fact done several liver transplants also during the lockdown, kidney transplants. So I think the clinicians have done really well, coping with all the challenges. And I think from the clinical side, it's really been fantastic. I think what we've seen is that people have really pushed and worked really hard beyond the call of duty, working 24/7, managing their facility, also finding time to learn, because I think the kind of data that we are seeing now is huge. To just give you an idea, as of half an hour ago, there are 8,437 peer-reviewed published papers on PubMed with COVID-19. But COVID-19 is only 123 days, so that works out to 69 peer-reviewed papers a day. Now, we all know how much time it takes to just read a peer-reviewed paper and then to understand that and then to review whether it is going to be practical or not is not easy. So I think the kind of information that we have is just humongous. And I think making sense of it has been a challenge. And also what we start off today might actually be irrelevant next week. And then, of course, in between, we are bombarded by what patients read in the press and their concerns and queries about it. I mean, in terms of therapy, again, trying to see what we can use with the kind of evidence that we have is a challenge. 138 potential therapies, 115 candidate vaccines, 180 trials, different types of trials underway, and another 150 planned. So I think just keeping up with what is happening with COVID has been quite a challenge. And I think it doesn't seem to be getting less, because the number of papers that have been added over the weekend is several hundred. So clearly this is going to be something that we're going to have to learn to grapple with. Joy wanted us to talk about what we are going to do in the future. So clearly we need to figure out, how we're going to move forward. So we've been brainstorming with our teams across, and of course our hospitals are different size, different location. Some are semi-urban, some are in metros. So the needs, the requirements are very different on how we're going to reopen. While we've continued to provide essential services, but I think we will now need to go beyond that. So we've been having discussions with teams about a staggered approach on what services are we going to start in phase 1, and then what we can do in phase 2, and then what we can do in phase 3. But I think one of the key challenges really is going to be about getting patients back, in terms of the fear psychosis that a patient has today is unprecedented. I don't think we've seen anything of the degree that we are seeing. And again, that's largely because of an information overload. And if you just did a very simple test, and that will sort of give you an idea of the information overload. So type diabetes, you get actually 620 million results on Google. And diabetes was first described in 1500 BC. Type COVID-19 and you get 2.6 billion results. So what we know about diabetes, we have 4 times more information for a disease that we've known only for 123 days. And with this infodemic that we have in addition to the pandemic, and most of this information in the lay press is quite often about this can go wrong, that can go wrong. So anyone who consumes that kind of information is really going to be petrified, and I think that's what we are seeing. So I think the first step for us towards rebooting is really interacting with our patients and convincing them that, you know, life really does need to move on, and we will have a new normal, and that's a new normal that we have to accept. And this also means that there will be certain types of treatments that we will offer readily and some we will not. But this fear psychosis now has to be handled. I think what we have is a unique opportunity to really relook at processes, because I think in medicine, quite often we are very fixed in our ways. And it has been said that it can take about 100 years for a good idea to come into medicine. And this was published once, that we really do need to look at every process that we have, look at all the SOPs. There's a unique opportunity that we have to revisit the way we run. You know, how do we look at waiting times? How do we look at turnaround times? You know, how do we handle, you know, the gaps between patients, whether it's in the OR or in radiology? How do we schedule? How do we handle the discharge process? What all can we do before the patient comes in? What all can be done virtually? Where all do we need a physical consult? And I think clearly, as we have discovered in the last few weeks, a lot of the world is going to move towards teleconsults, telehealth. And that is something that we believe we are already seeing a lot of traction through our Apollo 24/7, which is seeing more than 1,200 consults a day straight away. And many of these patients we believe are not going to come back for a physical consult, because sometimes if you're just going to change medication based on your blood reports, you really don't need a physical consult. So I think tele consults is really the way forward. We've started using a lot of teleradiology. And I think EICUs, the amount of cases that we are seeing managing out of EICUs has increased. So clearly, I think we're going to get smarter about tech, and I think that's really fantastic, because I think this was needed, and COVID-19 has given us the opportunity. What has also been very remarkable, and I think this is really very positive, is how we have all come together. All the silos that we lived in have been broken. The way we've gone about looking at trials, the way the vaccine trials have commenced at breakneck speed, how the genome was unraveled of the SARS-CoV-2 in a matter of days. Stuff that used to take years is now taking months to weeks. What used to take months is down to days. So I think, and all that has happened because of the kind of cooperation that we are seeing. We've seen another very good example of that. There are 1.4 million doctors of Indian origin in the world. And from 45 countries, we've launched the Global Indian Physician COVID-19 Collaborative. And every week, we meet, we deliberate on different areas, and it's amazing to see the participation from New Zealand and Australia to, the remote areas in Canada, what the learning is. And I think this breaking of barriers is something that COVID-19 has done. I think it has given us a lot of energy. And with the kind of collaborative spirit that we have, I'm pretty certain that we're going to see remarkable progress. We believe we must, we will, and we most certainly will conquer COVID-19. And I think the world that we see in the next few weeks is going to be very different. It's going to be a world where I think we're going to redefine how we look at healthcare. And I think there is a fantastic opportunity for us to become more efficient, more tech savvy, and actually meet the patient expectations in a manner that we thought wasn't even possible. I'm going to stop there, and over to you, Joy.
Thank you, Dr. Sibal. And I'll go to the next panelist, but two things. One for Dr. Bhudhiraja and for Dr. Sibal. Soon I'll come back to you to ask some of the challenges what you're coming across in areas like emergency department, or managing your dialysis or daycare patients, or even ICU. What kind of issues and challenges you're coming up? I'll come back to you with this question soon. And I'll request the viewers to post questions, and you can specify for whom you're asking this question. And at the end of the session, I'll be picking up some of those questions from there. So I move on to Dr. Vishnu Panigrahi. He comes from Bhubaneswar, and I heard and I happened to get some of the first-hand information from him, the way Government of Odisha is working with the private-public partnership model. And congratulations, Dr. Panigrahi. We happen to hear that you started the COVID hospital in a record time of 1 week. And then yesterday you happened to share that the CT scan came up, a 64 slice CT scan came up with an effort of 10 days time. So congratulations for that. And I want to ask you that you are creating one of the biggest COVID hospital in Bhubaneswar. Can you share how private-public partnership is working to create this kind of model, and how it is going to work in future too? Over to Dr.
Yeah, good evening, everyone. First, I'd like to thank CAHO and Dr. Agarwal for taking this up. Enjoy for comparing it. And it was very nice to hear Mr. Pardeshi. There were a lot of insights for it. And for two of my former colleagues from Apollo and from Max, where I also worked earlier. But coming to this, I think so the public-private partnership is there to stay. I think so there was a lot of mistrust, if I can put it, between the private sector and the government sector. And I think so all of us have to work together, and we can scale great heights. And I think it depends on the leadership. I think so here, this is where the Chief Minister of Orissa, he realized that to scale up, my word is very important, to scale up in an efficient way, you need to reach out, and they need to reach out to the private sector. That's what happened. because in fact now there are 4 private sector groups who have partnered with the government of Orissa to set up hospitals across the state, not only in Bhubaneswar, across the state. So and to do it in a quick manner, because it is just like emulating the disaster management which Orissa did with the Filin, if you could recollect, the Fani which happened, the super cyclones. Because we don't know, we are lucky that we didn't have too many patients coming in, but you never know. If you have a 50,000, 100,000 patients coming in, you have to be prepared for it. So for this, what he did is that he reached out to us. He asked us whether can you all do it, and how will you go about it. So the 7 days thing happened because we had a 6-story building which was housing the medicine block, high-end gastro suite. So because of this lockdown, we had a drop in occupancy, which has happened across the board, across the country. So we shifted out all our medicine patients from there, our gastroenterology patients from there. And so a 500-bed hospital was there. We had ICU, we had HDUs there. So it was just to say that we are ready. And so that's how we, within 3 days, we agreed to it. We signed the MOU, and they said, let's start. The one catch was that because all our diagnostics was in the main block and not in the medicine block, so we can position the X-ray machine, ultrasound, and all that. That's okay. But a lot of patients do require a CT. So we could fast track it, and we managed to get a 64-slice CT within 10 days, and patients are getting the benefit of that. So I think that reaching out to the public sector, private sector, this partnership has to be taken forward, and it's a question of trust.
So thank you.
And just so let me finish with this. Sorry, the other thing which happened is that I'm not talking about only Bhubaneswar. There are three medical colleges which partnered with the government, setting up hospitals in Bhubaneswar and outside in Raulkela, and also in every district. Like we have come up with 3 hospitals in Pulwani, in Baripada, in Mayurbhanj, 200 and 150 bed. So totally, the KIMS organization manages about 1,050 COVID hospital beds. The other medical college manages around 700. Then there's another private in Raulkela, they are managing. Another hospital in Cuttack, they are managing 150. So I think so. This is how they have come up, and because they were able to scale up quickly, they could manage. And it's a very strange thing that the government has, in every district, has put up the centers, and they have earmarked some of the major private sector players who have reached out to be the nodal centers going forward.
Okay. So it is really a nice thing to hear that how the private-public partnership is going to work there and how the infrastructure is getting scaled up. I even open not only the viewers, but I also request the panelists to have questions for the other panelists if they have, and there can be a discussion on that too. So,
Joy, a couple of things which I wanted to just highlight was when we started off, we had a huge issue with the PPEs because there was a worldwide shortage and there was panic across. And this is where the government chipped in. In fact, they used the state planes to fly PPEs from Delhi to Bhubaneswar. They ensured that the PPEs were supplied to us. And so that was a huge advantage that we had. And then in initial lot, we did get a lot of substandard PPEs. But just to inform the group across the country is that there are ways to see that the PPs are proper, because there's a CITRA and a DRD certification which has to be there. So it's just information which I didn't have earlier, but I came to know recently, which I would like to pass on. Because CITRA is the South Indian Textile Research Association, and the other one, DRD, which is based in Coimbatore, and DRD is the Defense of India setup, which is there in Gwalior, which tests a lot of equipments for the biological warfare or which can happen. So unless you have these 2 certifications, please don't go for any PP without these 2. So this is a learning which came up. The other thing which actually would like to say is that the number of there was a long turnaround time as far as the tests were concerned. So as we heard from Mumbai, that the government facilitated this. So even in Orissa now it has ramped up, but still we are not as good as the Marshal government has happened. But the other thing which I would like to point out is that which is a message that has to go out from all the clinicians, is to tell the public outside, do not wait, because what's happening in this fear mongering, a lot of patients who should come to the hospital, non-COVID patients, are missing out. Day before yesterday, we had an incident where a patient was delaying, and by the time he came, he had a massive MI, he could not be resuscitated. So it's a message that we need to share amongst each other and pass on to the public outside, that there is COVID, it will be taken care of. But if you are having any problems, please reach out to your nearest practitioner or reach out to the emergency services, whichever area of the country you are.
So thank you, Dr. Panigrahi. And one of the things, as you told about the quality of PPE, it was a major concern even for Mumbai, for us. And here also the BMC has given the job to Hafkin Institute, and they are giving certificates for the PPEs, what should be sold in the market. And with that certificate, only hospitals are expected to buy PPEs. So with this, I move to Dr. B. Keshav Rao, and we are going to ask him a little different thing. And we heard about the death, mortality due to COVID, as well as about due to non-COVID. Now, most of us, when we are only talking about COVID, and hospitals are getting, busy with managing of COVID patients, what is happening to the non-COVID patients? So my question to Air Marshal Dr. B. Keshav Rao is, what are the challenges posed by non-COVID diseases during this COVID-19 pandemic? So over to Dr. Rao.
Thank you, Joy. And I'll just take a cue from what Dr. Vishnu ended with. And he talked about a young man. This young man developed chest pain, and he first had to convince a whole lot of security personnel at various blockades to convince them he was not just one of those lockdown offenders, and to allow him to pass to a hospital. And he went to a number of hospitals, and because he came from a particular hot or containment area, I'm told that he was not attended to, and finally when they took him to the dedicated COVID center, he had died. Now, ladies and gentlemen, in India, we encounter about 10 million deaths a year. If we talk about disability, and we use a metric called daily or the disability adjusted life years, we have 500 million dailies per year. And out of these, 55% are from the non-communicable diseases, 33% are from communicable diseases, and that includes perinatal and nutritional disorders, and 12% are from injuries. Now, where have these patients gone? If we talk about April or May in 2019, all our urban hospitals were flooded with cardiovascular disease, with diabetes, with neurological disease disorders, orthopedic problems, gastrointestinal, respiratory, etc. And I would agree, of course, all of us would agree that because of the reduction in pollution, there would be a slight dip in the respiratory conditions. Before, or the lack of movement, there would be some reduction in the amount of injuries, but only a small fraction of the disease burden. So what I bring to you today is that while all of us are rightfully so focused on COVID-19, what is happening to these other morbidities? They couldn't have just disappeared. So locked down at home for the last 6 weeks, these patients must surely be suffering, being denied optimal and timely treatment. Now, let us not get carried away by the media blitz bombarding us with nothing but COVID-19. Western Europe and the US do not have the public health problems like we have. And if our civic administrators, and I'm so glad that Mr. Pardeshi at the start mentioned about how the civic administration is looking after much more than just COVID isolation. But if civic administrators take their eyes away from preventing infections and vector-borne diseases, we may undo the benefits that have accrued over decades of effort and find a resurgence of malaria, encephalitis, etc., or infectious diseases. Now, if you go back to that young man I mentioned at the start, and We look at any case of, say, unstable angina or acute coronary event, and these people in the lockdown period and right now would be on medical management, suffering, and maybe dying at home. Have we, while we focus on COVID-19, have we set the clock back for several decades to when primary PCI was never an option? Or take the patient maybe with a simple backache, a PIVD, for instance. And would he be denied the advantage of neuromicrosurgery till he finally gets a foot drop? Or if there was a young child with acute leukemia, would that child be picked up when the child had the very first bleeding in the gums? We could go on and on, but I think it's time for us to rebuild our army of non-COVID warriors, to fight shoulder to shoulder with the COVID warriors to deliver more balanced healthcare. Several changes in the way we address our routine patients, and Dr. Sibal mentioned that in his talk, have been forced upon us by the COVID-19 pandemic. Let me just take you through a few of them as we envisage them in Fortis Healthcare. Telemedicine and teleconsult that has been mentioned, it's the need of the hour, and once practiced judiciously will be the new normal. If governmental guidelines and those of Telemedicine Society of India are followed, the transaction can be completely safe for both the patient and the clinician. Home care and mobile treatment platforms, healthcare at the doorstep. The classic examples of physiotherapy and home collection of lab samples can be extended further. Home peritoneal and hemodialysis or oxygen treatment managed remotely. The intensity, the scope, and the quality of home care delivered can be greatly enhanced. Now let me say a few words about safe hospitals. A video did the rounds in early April, put up by a Singapore hospital that said, in the current situation, the safest place to be in if you're in Singapore is our hospital. And we must achieve that sort of a claim to give to our healthcare workers and to our patients the confidence to not neglect nor postpone appropriate medical care. Let me take you into an emergency room in the current situation where there are both COVID and non-COVID patients coming in. Breathlessness, the ancient adage of cardiac asthma versus bronchial asthma, is now replaced by COVID and non-COVID dyspnea. A known cardiac patient or a known asthmatic may present with COVID-19 infection. So as to err on the side of safety, the ER would cohort these patients in the COVID suspect area, something the patient or the attendant or even the non-COVID clinician may not really want. But to reassure everybody, the strictest infection control measures apply to this common area, which should house temporarily both COVID and non-COVID patients. And this area has a dedicated staff and point of care equipment like ultrasound, echo, ECG, X-ray, ABG, etc. Once stabilized, the patient is then transferred to a common ICU. And only after thorough clinical judgment and if possible an RT-PCR test is this patient finally shifted to the hospital's clean area. In our hospitals, we keep such patients in single rooms. Our present low occupancy allows us the luxury. Let me shift to the cath lab, for instance. Now, primary angioplasty versus thrombolysis is a debate which will continue as long as this pandemic lasts. But in days ahead, more patients will be taken up for PCI to avoid mortality and significant disability. We must create as safe an environment as possible to allow the cardiologist to provide the optimal choice and for the patient to feel safe in accepting it. Going forward, the decision to thrombolize the patient should be based on efficacy of the procedure and not on pure relative safety. Ladies and gentlemen, even when we come to surgical procedures, there would be a requirement for some sort of a restructuring of the operation theaters, upgradation of equipment, maybe modification of processes. And all these efforts to allow patients their right to optimal, safe, and timely surgical intervention. To conclude, to the civil administrators, I would say, don't drop your guard on prevention of vector-borne and other communicable diseases. The hospitals, I would say, make hospitals as safe as possible, focus on the common areas, and for patients, follow all government instructions meticulously and do not delay in getting your treatment done, and trust your hospital and your doctor. Thank you.
Thank you, Dr. Rao. And it is very important that hospitals must follow the guidelines and the policies which have been made by the government. But what we are coming across that different states are issuing different types of guidelines. For example, one question which has come up, that testing on OPD basis. So that is a scenario in a state, another state, where testing is not done on the OPD basis, whereas in Maharashtra it is done on OPD basis, and it is encouraged to get more and more number of patients to get tested, or more and more number of people who are symptomatic, asymptomatic, to get them tested and identify who are positive. So we know these are the challenges we'll have ahead of us, and we have to work in that framework. And with that, I move on to Dr. Lallu Joseph. And as she comes from a premier institute like CMC Vellore, where for a long time, the quality healthcare has been delivered in a sustainable way. My question that whatever we have discussed so far, that can be delivered only when you have a good workforce. In this case, I'll talk about healthcare professionals like doctors, nurses, paramedical staff. So when you run your own hospital and you manage COVID patients, and in this environment, what are the challenges you are coming across with the doctors, nurses, and other staff? And what are the kind of fears they have in their mind, and how are you planning to mitigate those?
Good evening, and thank you very much for this opportunity, Mr. Joy, and all the panelists for the wonderful session. It's been really interesting. And I think to start with, all of us probably get up in the morning, checking our throat and probably just touching our cheeks to see if we are running a temperature. So that's the level that we have all reached. It's inevitable. And as Dr. Anupam rightly said, it is infodemic during the pandemic. And that's what is causing the major chaos, I would say. Now, the major challenge has been managing staff, whether it is the doctors, nurses, or even the housekeeping and laundry, linen management people. It's a huge challenge because I would say the biggest threat for a healthcare worker is the fear of infecting, first of all, themselves and also putting their families at risk. So it's extremely difficult during this pandemic, particularly people who have never seen infectious diseases are made to manage these patients. And interestingly, some of them haven't even seen a N95 mask, and now they are made to wear these masks and the astronaut hazmat suits and everything. It's not easy at all. It's a lot of fear psychosis in the industry. I think it is all coming down slowly, but yes, it's a totally different atmosphere that we are in now. And exhaustion, that's another aspect, which is with regards to people who are managing in the front line. Now, we've all been talking about managing patients, talking to them very frequently, explaining things to them, do more rounds, talk to the patients has been the mantra all through. Now we are trying to tell them, limit your visits, don't overdo, don't go too much into the areas. So it's a kind of a paradigm shift, and it is very difficult for healthcare workers to adapt to a situation like this. Now, coming to think of the patients, they are in isolation. They don't have their relatives, their near ones, loved ones close to them. And at this time, we are encouraging social distancing. And of course, technology is a big boom at this point in time. But yes, it's extremely difficult to put more manpower into this area. We are trying to reduce the manpower. So yes, it's a difficult situation at this point in time. And even the psyche of the doctors and nurses are not tuned to keeping patients in isolation, not visiting them often. It's a little too challenging at this point. Now coming to the personal protective equipment, that's again a huge challenge. Who should use what and when to use what? And everybody wants everything, starting from the suit used in China to the respirators and everything. So even a typist who is sitting in the front desk they tend to ask for the N95 masks and other. I mean, it's extremely difficult to explain to them, saying that this is a category that requires what. So we have not been functioning like this so far with limited resources. I think most of the hospitals face this challenge with regards to explaining to their healthcare workers about reuse of PPE. That's another thing. When it comes to N95 masks, resources limited. So now you're trying to tell them the ones that were earlier thrown away probably after 8 hours of work. Now you're conserving them, using them for 5 days, and then sterilizing them, once again using them for another week. It's really not easy to tell them because the apprehensions are extremely genuine, and to allay the fear is challenging. And the other thing is, of course, our surgeons, anesthetists, so far we've all been talking about a positive pressure environment, trying to protect the patient from infection. Now this entire concept of positive pressure in OT is getting converted into negative pressure. Which are the areas that you could provide negative pressure? What to do? Are we going to test all the patients? Now, if you're not going to test all the patients, everybody is in a state of paranoia. Now, when to start electives, what are the procedures to do, what are the ones to avoid, everything has been challenging. And particularly in hospitals like ours, where we manage a huge load of delivery, in the lockdown, patients coming from the lockdown areas, and then you have to test them, you have to screen them, and these mothers are actually kept alone, and to give them the kind of counseling, talk to them, the consenting process, they're as it is scared, young mothers, young girls. And now here you have to keep them isolated for some time. God forbid, not many of them are turning to be positive. But yes, that again is a very challenging thing for the healthcare workers, seeing these patients also suffer. So I would, by and large, say it's extremely challenging, not just for the healthcare workers, but also to see the way the infrastructure needs to be tuned up, the availability of resources, seeing the patient struggle, and the fear of taking infection back to the family, the fear of commuting and coming, all these have been really, really difficult. But I think by and large, all of us have kind of managed pretty well, talking to them, trying to have meetings, Zoom meetings all the time with all the heads of the departments, and the top management has really got involved. In most of the hospitals that I'm talking to, it is really driven by the top management. So that communication to the heads of the departments, and they are standing with their departments trying to explain things, has really gone, bringing about a team culture in the organization. I feel everybody is now working more closely, and the concept of silos are slowly moving out. So that seems to be a definite advantage in this situation. Now, coming to other challenges of training, I think the technology has been a great enabler with regards to training of staff. We have not faced major problems training. Of course, the age-old system of having all of them in auditorium and having a group of 200, 300 people trained, that is now gone. It's smaller groups. Also, more and more with technology adaptation, which I feel definitely has been a different way of thinking during this pandemic. Thanks, Joy. I think I can go on and on with the challenges. Lot more of challenges.
Thank you very much for throwing light on so many practical aspects of it, and I'm sure many of us are coming across these, and every day we are learning. And I can tell you, in last 2 months, though being a non-clinical person, I didn't have much idea about the PPE, but I can see that every 7 days, 10 days, the level of PPE, depending upon the area, it has changed, and which is a great learning even for me too. And I'm sure that is the way all of us are learning, and we are adapting ourselves in that environment. Now I move on to Dr. Vivek Desai, and he doesn't require introduction, and he has focused on this hospital planning, healthcare planning, architecture bit of it. And question is, during this time of epidemic, hospitals are ultimately coming across and realizing that during the construction, if it is an old hospital especially, during the construction of those hospitals, there are certain lacunae they had, and which is becoming difficult for them to overcome during this COVID-19 when they want to admit COVID-19 patient or they want to create isolation ward. So I want you to highlight some of those challenges what hospitals are facing, and after that, what kind of intervention should be made by the hospitals to avoid this kind of similar scenarios in future. So over to Dr. Desai.
Thanks, Joy, and thanks to CAHO for putting this up. I think I am the odd man out in the whole thing because I'm not going to talk about operations, but more about how hospital planning and architecture can play a role and what are the deficiencies that we are seeing now. So I've had some experience of existing hospitals like yourselves, or say Jaslok, which is an old hospital again. Most of these hospitals probably are facing the heat from the angle that when they were designed, they were probably not attuned to the spaces which we now generally keep, say the corridor widths or the daycare spaces for hospitals. So waiting, I think, is becoming a problem. In most of these hospitals, there is no space and you need to keep social distancing. So I think the thumb rule norm nowadays we tell is about 800 to 1000 square feet per bed. Whereas the older hospitals are having an area of maybe 400, 500, maybe 600. And nursing homes are even lower than that. So in smaller towns, when you build a 50-bed hospital, you have hardly any maneuvering space for waiting and other things. So that is one of the issues that we are going to see. Most importantly, actually, no hospital was planned for infectious diseases. There are probably in every city couple of hospitals, mostly managed by the government, which are for infectious disease. Suddenly, from a technology-centric healthcare, we are facing a problem of giving basic healthcare like isolation, like quarantine. We are not prepared because we never thought that something like this will come up. So this is a low technology kind of a solution that every hospital is now looking at. So the future, when you are looking at hospitals, you will need to be more flexible in your design. So that starts right from the column grid, So we generally will now have to plan for a larger column grid, which is able to take a intensive care unit, which is able to convert very quickly into an isolation ward. Okay. So that is the one major thing. So 8 feet to 9, 8 meters to 9 meters is a good column grid to go with. I think future hospitals will have, that kind of thing. Waiting areas will go up because we have felt that we don't have enough waiting spaces. There will be emphasis on less touch or no touch kind of, either technology or usage of, design principles to do that. For example, most of these, electronics that you have in a hospital, and you could see that in Runagrad Hospital in Bangkok, where, most of the electrical instruments are monitored by a remote control device, which is in the hand of the patient. So you're not touching, the plug points and the switches inside the room. Even the handles of the doors probably will be now more foot operated if they can. So, there are, you can open and close a door through a foot operated, so a lot of furniture ergonomics are going to undertake a lot of changes. You will also need to concentrate more on the airflow and the air control, the indoor air quality. So when we had visited Seven Hills hospitals with a view of ramping it up to a 1500 bed facility, we suddenly realized that they didn't have negative pressured room. And then when Dr. Taran came from Hakisandas Hospital, she insisted that she would need that 30-40 rooms that she is going to use with that kind of technology. And I think many other hospitals are now converting some of the rooms into negative isolation, because you need 3 types of patients to be monitored. One, that you need to be quarantined, like Mr. Pardeshi said in the beginning. You could convert a stadia or an exhibition hall and you can put them in. They don't need to be looked after very aggressively. Then comes the positive, the isolation for positive cases. This needs negative pressured air, where it need not be air conditioned. So it is not, for current scenario, it need not be air conditioned. For future hospital, it should be. What is the principle? That you are throwing out more air than what you are taking in. So just by exhausting air system, you can convert a positive, convert any room into a negative, kind of area. But most importantly, most of these beds will need oxygen supply. So that is going to be, currently, if you go to general wards in many hospitals, people tend to put one oxygen point between two beds. I think in future that is going to change, because you will need this. You will also probably think of doing a line of, oxygen in areas which you probably never thought of. I mean, something like a parking lot, which needs to be converted into an isolation ward very quickly. You just have to run a line, and you can, the plant size probably will undergo a change. So we had done this again in Seven Hills when we were looking at ramping up. This was one of the key elements that came to fore, that you need to do this very quickly, because 80% of the cases which get better would need oxygen supply support, and COVID-19 is not going too soon. Even after you get a vaccine, it probably will come up with COVID-20 or 21. So we need to be prepared for, things like that. Most of the furniture items or the surfaces of walls or the flooring, you will need to use material which is sanitizable, or, which can be cleaned with a wet mop. Okay. So very soon you will see curtains will go out of wood. You will see that all tapestry of sofas and everything will be something which you can clean, with otherwise those are useless, because it will gather dust or virus, you can't remove them. So that is another thing which will change. The one more thing which I can see happening is, we in India, though we are capable, and I think most of the IITs are now working towards that, how you can bring in robots to deliver the hospitality part of healthcare. So suppose I am taking a lunch or a breakfast tray, or I am just delivering some, medicine and just giving it to, how can I use that? That's I had a friend, a pilot in Air India, who was admitted as in a hospital in Bombay, and the ward boy was very, hesitant to even hand over. He was throwing the medicine, and other supplies to him. So that kind of a fear that has set into people's mind probably will go better with, if you take a robo, and so that is going to come up, whether, and it will be successful. Waste management systems. I mean, the number of PPE that we are using today, how do you, get rid of that? Maybe some of the panelists can, share their experiences. CMC Vellore probably would have, Dr. from Orissa would also have PPEs in large numbers, and how to, do away with it, so that will be another issue, waste management. I think, you will see more and more of virtual healthcare in the future. So all hospitals will set up this telehealth solution within their, system. I think Narayana has been doing that for quite some time. Apollo has a separate unit, which does that. But I think most hospitals now will use this. I think Hinduja Joy has done very well with, tele-consulting, but this has come to stay. This is not going to go. The other thing which, hospitals will look at, it's not a design solution, but it would be home health care, because a lot of patients will not want to, come in. So I was seeing some WhatsApp video clip from Israel where, doctors were monitoring patients, and very simple gadgetry, with a pulse oximeter, a thermometer, and there is a, cardiac stethoscope kind of thing. And they were monitoring from, from their control command center. So that kind of thing is going to come. I think overall, when you will look at it, there would be, from a government angle, government had till now, and not only in India, because even the best of the countries, healthcare is supposed to be best, have suffered the most, be it Spain, be it Italy, be it United States, be it the NHS system of UK. So we that way have been a little lucky, because of, the earliness of lockdown probably worked in our favor. But the urban health system, you are going to see a sea change, and not only urban healthcare, it will also be government spend on healthcare, creation of healthcare facilities, which they were earlier shying away from, probably will now come to the fore, and you may not have very high-tech, high-technology hospitals, but you would need probably hospitals which will work in a pandemic kind of a situation, because technology can be plugged in. But when you create an infrastructure, of a hospital, you cannot do that, because it takes a lot of other things. You need water supply, you need sewage systems, you need air conditioning systems, so it's quite expensive to do that. How governments respond globally, we'll have to wait and see, wait and watch whether government now spends more money, and takes it upon itself, or it still pushes private sector, because private sector, unfortunately, has faced the brunt of this pandemic, though they are willing to, support, but they're not probably geared to, do that, because very quickly, their employees get infected and the hospitals almost get, shut down. So in those kind of situation, I think the Zydus Hospital in Gujarat, or I think Apollo also in Delhi, have done this, what do you use, those pota cabin kind of a system outside of the hospital in their campuses, so that these patients get treated outward and not inward, so the inside hospitals probably, so mobile healthcare, what our government is also doing with Indian Railways, that it is better and easier to take a railway network to a remote village where you cannot create a hospital in short term, so that's a very brilliant idea. So similarly, we will probably have to have these fallback measures of, pota cabin convertible into isolation rooms, or mobile healthcare, or tented systems, which we are working with the army in Saudi Arabia, where to create a tented hospital in about 7 days time, so these kind of, solutions probably will need to be thought of and kept ready to be executed. The other thing that probably we will also need to do is more focus on diagnostics, because I think we were lacking that when it hit us, so we only had maybe one lab in Pune, and then we started ramping up. Now, of course, there are a lot of other hospitals, and I think still private hospitals find it difficult, to get recognition for that. But I think that is something which, say the Seven Hills Hospital, when looked at that, they had to send samples to Kasturba or Hafkin, so that was not you need a laboratory on ground, because you are the epicenter of, so laboratories will come up, radiology, required, because it's a lung disease, you can't, fight it without proper diagnosis. So teleradiology also, will come into play, because a lot of hospitals probably do not have the talent to diagnose also many a times, CT scans, MRIs. Bronchoscopy is something, which this, so you have had SARS, you would have MERS, and now COVID, all are lung diseases, which are there. So effort on bronchoscopy. And such rooms need some technical input in terms of the airflow and indoor air quality. You probably will also need, some emphasis on things which probably is like change rooms, for example. You don't have that many rooms in a hospital. So when you are, say, converting an outpatient clinic suddenly into an isolation ward, possible to do it, but you will need change areas, waiting areas, toilets, and those kind of things. So in a hospital building of future, you would probably need to keep a service line kind of a shaft periodically, so whenever such kind of things. So in Western world, this has been done. I think Medanta, if you see the design, it's been designed like that you have kept, ducts for services, not knowing when you will need it. Okay, so these kinds of things probably are going to come in.
Thank you, Dr. Desai. And as you told about teleconsultation, which is going on and become very popular, I'm pleased to say that robot, what you were talking about, the hospitality bit of it, that we are getting in Hinduja Hospital, and we have identified that. And most importantly, what we are seeing, that after the lockdown gets over and more patients start coming in, at that time the registration and sanitization of the patients, all these activities will be picked up by the robots or in a automated system. So
we now also have a digital sanitizer, it's a no-touch sanitizer. It's like a sensor-based sanitizer.
Yes.
Up to 40,000-50,000.
Yeah. I move to our next panelist, Mr. Rupak Barua, and he is a person running few hospitals, and we would like to know from him that during this COVID scenario, in one hand, we have less occupancy in the hospital. So hospitals are struggling in terms of keeping their beds full or getting revenue. On the other hand, when the COVID patients are coming, there are issues with the chargeabilities. There are certain states which are coming up with the regulations in terms of the chargeability, what is applicable in their particular state or city. And at the same time, cost of PPE, cost of testing, everywhere patients and public policies, everyone is expecting that hospitals should give or provide things either free of cost or at a subsidized rate. At the same time, the employees are running a hospital that is going to also, going to incur a lot of expenses. So keeping both the sides in the mind, my question to Mr. Barua, how do you think a hospital can manage these financial challenges what they are facing, and how someone can think of coming out of it? So over to Mr. Barua. Please unmute yourself. Please unmute yourself. Yeah.
Thanks, Joy, and thanks, CAHO, for the beautiful kind of an interactive session, quite learning session. Everybody, we are learning, and thanks all the panelists for sharing their all views. It's because you see, COVID is a very new chapter in the medical science. We are learning a lot. Daily basis, we are learning so many across the places. So I would like to keep myself within this your financial part, because that is the bloodline actually. So if that is stopped, actually how the heart will function. Before I would like to say little bit, I would like to talk about that's the private healthcare, because more we are talking about here is the private healthcare. See, private healthcare, if you see, and whatever I'm saying as a private healthcare, I'm saying about what are the activities we are doing to cope up with the situation. Challenges are many, but talking about the challenges is not going to help us until and unless we are looking for the solution, because COVID is going to stay with us, as Dr. Vivek was mentioning. So you see, private healthcare actually in this in India about this is a more than 60% capacity, and more in this your secondary and the tertiary care regime, and 8.5 to 9 lakhs of the beds we are managing private healthcare sector, and the more than 60% of the inpatients. So it's a huge amount of services we are rendering to the citizens. Now, if we are talking about the revenue, I'm talking about the normal kind of a situation. This revenue is almost is a 2.41 lakhs crore is the private healthcare sector revenue as a whole. And if you are talking about the EBITDA where we manage our institute organizations, it's almost is a 31,000 crore. If we take 13% is the EBITDA, standard EBITDA across the locations. Now here in the situation, if we are talking about the sector is constrained severely, if you are talking about in terms of the liquidity, that is the major issue right now we are facing. The cash balances, usual time, the cash balances available to cover up to 19 days, not more than that. I'm talking about an approximate figure, estimated figure. 19 days we can maintain our cash balance and the operating costs as well. And the government actually receivables the tune of almost maybe 7 to 8% of revenue. So that is the whole situation. Now, in this kind of a COVID situation, where is in the strict lockdown measures has already been imposed, and to contain the outbreak COVID, there's a one part that the hospital is facing and witnessing the drop of your footfall, both domestic, forget about the international, because that has already been banned. And elective surgeries has already been, we have deferring the elective surgeries, resulting in occupancy levels. If we are talking about almost 40%, what we have seen last March, because your lockdown started 22nd, 23rd of March, and that we have observed that is a 40% of this your occupancy. Now in the month of April, it has come down to 30, 32%, 35% max to max. That is the situation. And we are expecting that the pre-COVID occupancy, if we are talking about 60 to 70%, is the usual our occupancy level, that will come down, and your 80% fall in outpatient, that is going to fall in this time. Now, if we are talking about this, how to handle this situation. Now, operating losses, if we can see as a whole, the tune of 4,500 crore operating losses I'm talking about, is it monthly? If you consider it's a quarterly, because you will have to consider Q1, April, May, June, at least for the time being. It is coming around 13,400 CR it is coming. If the quarter of the revenue 50% down, I mean, we are considering estimated. Now losses are estimated. If you see the private healthcare sector is almost in the tune of 7,300 crore losses we are going to face. And if you consider this in the quarter, 21,900 crore of the losses which the whole private healthcare sector will have to face. Now, if you are talking about this year, while the utilization, if you see the 80% of this year drop and private hospitals are expected to be absolutely super ready. If you talk about this, you're managing the healthcare now, there's a two part. One is the fixed cost and one is the variable cost. Now, fixed cost, where you will, there is almost 50%, 45, 50% or some better efficient hospital maybe can maintain with the 40% your manpower cost, the fixed cost. But now in this epidemic situation, we'll have to keep ourselves ready. So hence opportunity to reduce this your rationalizations of this your fixed cost is not possible. But unlike other sectors, some of the other sectors, they are following that rationalization of the fixed cost. They will not be able to manage these rationalizations of the fixed cost. Now the question of this year, that sector is expected to almost 20 to 35% down in terms of 20 to 35% if you are talking about revenue compared to financial year 20. So financial year 20 if you see and the starting of this financial year 21, so we are expecting that maybe 20 to 35% of the revenue will be able to manage in this financial year 20. And a single digit EBITDA, that's the EBITDA will have to be able to manage. So now the question of is how we'll be able to manage. One, I'm talking about what we are doing and what we can expect. So more state and the center, we can expect so many things. So in private care, we are expecting that the first is that we'll have to keep it, the cost of the total cost you will have to control. Expenditure you will have to control heavily in all segments. That is the operating cost and all. And particularly for you, this your PP and all those things, operating cost is going to increase almost 3 to 4% overall. So if you estimate that 25% is your operating cost, you'll be able to reach it to almost 28, 29% operating cost will reach. So that is one. So first, we can take care of our operating cost. We can take care of our power cost. We can take care of our whatever this your AMC, CMC part. We can take care of our repair and maintenance part. So these are the things we can maintain and we can reduce. Over and above, these are the costs. First, one thing also we'll have to take care, that is a liquidity infusion. That also we need to take care. We short-term interest-free, loan or soft loan, we can write to the central government for allowing this short term of loan, which is also will be around 16 to 20,000 crore. So that is the liquidity part that if we can get it around 16,000 to 20,000 crore, that the liquidity part will be able to manage. Now, one more thing that is that we need support. There is a 100% release of the outstanding. Where it's fine, there is a ECHS, CGHS, ESI, lot of your PSUs, the government outstanding, long outstanding, that we can take care, and we can, if we can get this your 100% release of those payments, then I think we'll be able to manage it. Now there is one part that relief that we can expect, that is the indirect tax relief. You know, that is the hospital sector, because the recoup amount which is equivalent to your ineligible GST, because we are not eligible for GST. We can manage that one, that will be able to make it, and the provide customs duty, GST, provide customs duty particularly, that will be able to take care. Now indirect tax relief, that is also one area, that is a waiver of health stays and all that we can also take care. Income tax benefits, that is a recoup of income tax benefits, we can postpone the income tax benefit. That is also one of the areas that we can take care. Then statutory liability payments, that is a ESI, PA, all those areas, that we also can take care, because it's a huge amount. So if we can postpone for 3 to 6 months, that's what we are trying to do it from our side as well. that also will be able to help us a lot. Now, fixed cost rebate, that is also one big area of concern. So that is actually a rebate on commercial rate powered for a stipulated period. That also we can look into, that is estimated power cost. If you see as a whole healthcare, private healthcare is 7,000 crore. It's not that very easy. So if we can get some kind of a commercial rate rebate, which one has to think of, and a government has to allow us for doing this one. Otherwise, survival will be a big issue. And there is one part also that we can take care of, the waiver of this. There is a lot of cost for the licenses and all. So that if we can see, these are all additional costs. These are all variable costs. Where you are not in a position to reduce this your fixed cost, mostly we have to depend on how we can manage this your variable cost. So once you can do this one, then I think we'll be able to manage the show, because this is not going to end shortly. It is going to happen. Your PP cost and all is going to increase. So you will have to see whatever expenses you are making towards the patient, you will have to recover that cost and you will have to sustain. That is one part. The other part also, one has to see how fast we can bounce back to our normal operations. This is one of the major kind. Each and every hospital, seniors, everybody should take care. How fast? There is a lot of, but considering everything, because that as Dr. Lallu was also mentioning, that is a little bit getting down, because that critical part we are removing the coming out of this scary part. So more if we can talk to the consultants, talk to individuals, the healthcare workers, bounce back to the system, start normalcy, more of this, as Dr. Vivek was also talking about, more of the digital part. Yes, of course, that is also more of the digital part connected with the patient. And then don't refuse the patient, try to accommodate the patient, whatever way possible, and start this your elective surgery. That will help us running of the hospital. If you start refusing patient continuously, don't allow the OPD patient's footfall to reach, and then fixed cost is same, variable cost will also continue, and the hospital will be absolutely, already it is bleeding in the normal time, more it will be in a very severe state, then you will not be able to, it will be, already it is in the critical care, and now you go to the ventilation, and then you will not be able to get back your unit for managing the show. So this is all my, what are the things we are doing at present, and I think everybody is doing. So more, I think we should work on finance. It is very, very important. Otherwise, we will not survive. No one will survive.
Thank you, Mr. Barua. And your wish list is long enough for the hospitals to adapt and ensure that they survive and bounce back. I'm sure that some of these where government is involved, they will be kind enough to ensure to support the healthcare sector to come back in the full swing soon. And wherever we have our own internal steps needs to be taken, we'll be able to adopt that soon. With this, I move on to Dr. Vijay Agarwal. We have heard about the challenges of clinical care side, healthcare system oriented issues, healthcare professionals, but I have a question for him, and as he's the president of CAHO, all the viewers, they want to know about what do you think are the challenges before the profession and the hospitals at this juncture? You have to unmute yourself.
Thanks, Joy. This has been a wonderful session. And of course, we are towards the end of this session. I'll try to be as short. I think one of the biggest challenge for the profession is again to face a challenge like what has really hit us in the last 2 months, when everybody is now drowning in their own boat. So nobody has the time to kind of look at the problems from a little distance, that you try to see and how can we help the whole profession. And that's where I thought, luckily, an organization like CAHO, which was created as a consortium of the hospitals, consortium of accredited hospitals, so that the small part of your organization has been pooling efforts into this organization for an eventuality like this. So, for example, moment it started, our organization could sense that digital health, just like the demonetization had spurred the digital transaction, we knew that this particular event will spur the digital health. But we also knew that the doctors were not happy doing teleconsultation because of some adverse court judgments and all that. So CAHO had gone to Supreme Court. So while the Telemedicine Society of India had been struggling, and they have been doing a great job, and in fact, they were very near, I would say, getting the guidelines out. But the process was that the guidelines would have been put for the public comments and so on and so forth. But since we went to Supreme Court, I think that acted as a catalyst, and we got these guidelines out within 3 days' time. So at least something could get started. Again, we again feel, all right, this hospital has started teleconsultation, that hospital has started telehealth. But we have to look at hundreds and thousands of small and medium hospitals. How do we guide them? Now, you will imagine that in today's date, there are hundreds of telemedicine solution providers have sprung up. They're like mushrooms. So we wanted that there is no registry of these telemedicine solution providers in the country. There is no evaluation so that it can be available to the, when I want to adopt it in my clinic or in my hospital. How do I choose someone? So when we started to do this work from CAHO, we also realized that there are 4 other societies who are equally trying to do the same work. There is a Digital Health India, there is a Chime and Telemedicine Society. We collaborated with them now. And as I'm talking, there are 140 platforms, and the vendors have shown interest. They have been registered. And from tomorrow, we have created a matrix for their evaluation. And very soon, so an end user can see, all right, these are the specialty platforms, these are the other kind of platforms. Now, that is the kind of challenge, I would say, in profession. We have been very used to working in silos. And especially, naturally, the big hospitals have always had, naturally, the advantage of that you have almost everything. However, I think a pandemic and a problem like this will make them also realize that it is a kind of a collective wisdom and a collective power which will eventually lead us to doing more and more good. So for example, now, like Anupam talked about the infodemic, or let's say, I would say the WhatsApp University is in fact educating each one of us with, I don't know, everything, right from, of course, yoga to this thing, but also very, I would say, useful things even about. So the issue is, there are now innovations happening. Now, who should collate these innovations? Where should they go for validation? So that's another work that, for example, now CAHO has started to do. We are collating the innovations. We are approaching various government facilities. We are in touch with Ayushman Bharat. They are saying, all right, they would like to do something with us on this matter. The thing is that if there are very interesting innovations, let me tell you, which are coming up at this time. There is a Bluetooth stethoscope which has been designed by one of the hospitals in Madurai, Meenakshi Hospital. Their own engineers have made something which was costing $800, $900. They say that it will cost them less than $50. So there is a huge scope for hospitals to benefit from, I would say, breaking the barriers, collective functioning. So while the barriers are being broken internationally, let us try to break the barriers amongst ourselves so that we share best practices. Now, one of the biggest problems for small and medium hospitals has been, and will become even more, is the supply chain. Now, collective bargaining is the way to go ahead, and we have to kind of get into these kind of things, and it can only happen when people have to break barriers and become a part of this, that how do I benefit not only my organization, how do I benefit everyone? Implementation of quality, so far the problem has been, it is more of accreditation for the sake of accreditation. A time has come when the implementation of quality should follow should precede accreditation. The stakeholders, I mean, all the people have to be involved in making the work processes, so on and so forth. I mean, I'll say that this topic of ours, where we feel that this challenge, which the profession is facing at the moment, I think can only be dealt by us coming together. And it is for this reason, in fact, one of the genesis of even this particular thing was to get somebody like Mr. Suresh Lulla on this platform. One of the thought processes that came about was that we as healthcare professionals may not be in the best judge to create a solution. There are people who have engineering solutions, they have management solutions, and they are like one of the best brains in the country. They are lying, they want to get connected with us. So when they work in isolation, they don't know what they are wanting to do. So that is where we wanted Mr. Suresh Lulla also to listen to the plethora of problems that we are having, so that he and his team, if they come out even with 2 solutions, 3 solutions, that again, of course, with the interaction of the healthcare people, we may try to bring about a better healthcare delivery system. It's like the problems can be seen almost like an elephant. I always like Mr. Suresh Lulla's one example. You cannot, the elephant in the room, you cannot tackle it all at one time. You have to take it bit by bit, bite by bite. So that is the only way we can try to meet the challenges in the profession that we are facing today. And this is not going to be the last challenge. I am very sure of that. Of course, at my age, I am in a way lucky that it has come in my lifetime, but hopefully I see more. So thank you.
Thank you, Dr. Agarwal. And as you told that we need to work together, that is the key of the whole issue, that if you want to work in isolation, it can't be achieved. And as you correctly told, to have Mr. Lulla with us, we consider as a quality guru, and always he educates us and he shares his wisdom time to time in terms of how to work in the quality journey, improve the process innovation, and how do you get solutions of some of the problems. And we'll be coming to him, but there are, I see 37 questions are there. I'm sure we'll not be able to take all the questions, but there are certain things which have come up repeatedly, and some of them have called and told me in practical way, what are the challenges you are facing in areas like emergency department, in ICU, in dialysis area, in daycare treatment. So I request Dr. Sibal and Dr. Bhudhiraja to take between them to share a few minutes that what are the kind of challenges they have, and if they have come out with some solution for this, and then I'll move on to Mr. Lulla.
Thank you, Joy. Obviously, these are areas where there are problems in terms of, with dialysis, chemotherapy, thalassemia, radiation. These are patients who are going to come in repeatedly. Dialysis patient will come 2 to 3 times a week. Radiation will come 5 times a week. Chemo might come every week, every 2 weeks. Thalassemia every 10 days. So we really need to have a very, very clear protocol in terms of screening, in terms of the checklist that we have to follow, and that's exactly what we've done. And we've been working towards making our facilities safe, COVID safe. So there's a very strict SOP, the walkthrough in terms of how the patient journey is going to be, what is the team that is looking after, training of the staff, what are the sterilization, disinfection processes. So that's as far as some of these areas where patients come in repeatedly. ER, of course, is very, very important, because if you look at data in terms of getting COVID, globally, the number of people, number of healthcare workers who get infected if they are working in a COVID ward is lower than those who actually work in the emergency or outpatients. Because when you're working in the COVID area, you've got all the PPAs and you're very serious because you don't want to catch it. Whereas sometimes you can be a little casual when you are in the ER department or in other areas. So again, we did an analysis of what are the risk factors that we need to work against. So we developed a protocol, we went through training, and we believe that we have a system in place that is pretty tight. We constantly look at it to see if we can find any cracks to make sure that we cement them. before we have a problem. This is a big challenge for every healthcare provider, big or small, corporate or non-corporate, nursing home to hospitals. And I think it's extremely important to have a team. This is a multidisciplinary team. You need a clinician, you need a manager, you need someone from nursing, and you need someone who understands infection control very well to walk through the facility just as a patient would or staff would, and actually look at all the measures that need to be in place. Over to you, Joy.
Yeah. So anything from Dr. Bhudhiraja to add on this? You're mute. You're mute.
Okay. So I would actually agree with what Anupam was saying. Just like to things, I think dialysis is becoming an increasingly critical area in COVID times, and increasingly we are seeing patients being refused dialysis in many hospitals for one reason or the other. And in fact, some of these units have been shut down because of some positive cases which were reported. And that's leading to two issues. One is of these patients now coming to hospitals which are providing these facilities. And secondly, many of these dialysis patients on maintenance hemodialysis who are getting COVID infection. So I think increasingly so this is going to happen, and one has to be prepared as a healthcare organization how we handle dialysis of patients who are COVID positive is number. So in our hospitals, for example, we have set up dialysis machines specifically which is taking care of these COVID positive patients. The other thing is, what protocols do you put in place in these areas like chemotherapy, radiation, and dialysis? Because these patients are definitely more at risk. They are immunosuppressed and at a higher risk of developing infections. And definitely the recommendation cannot be that you do testing. How often can you do testing in these patients who are coming to you 3 times a week? Essentially, it's strengthening your protocols, as was rightly said by Anupam. We have put a second level of severe screening in these 3 areas, where a second level screening happens by a doctor. And if all any suspicion that the patient could be having COVID, then of course the procedure is done in a separate isolated room, and of course the testing is in that case done. But I think ultimately one has to, as a healthcare organization, learn to live and an environment of COVID positive, and at the same time continue to deliver these most critical. I think refusal of these services by any organization at this time is the last thing one should ever do. And it's clearly the infection control practices, universal precautions. And one word of caution here is not to overuse PPE more than what is recommended. So if we follow these and, follow these to the T, I think one would say, presently, I can tell you from my experience, COVID hospitals are safest hospitals in terms of cross infections. Whatever infections are being reported are generally coming from hospitals where one is not geared up to handle possible COVID situations. And I remember those days when HIV first started and everybody spoke about universal precaution. I think it's a return to those days, and probably now for good forever. Thank you.
Thank you, Dr. Bhudhiraja and Dr. Sibal. Now I move on to Mr. Lulla. He has heard very patiently for last 1 hour and 45 minutes of different challenges and different areas of hospital, whether it is finance, whether it is human resource, whether it is process, whether it is the clinical protocol, clinical outcomes. So we want to hear from him, what is his advice, what is his suggestion in terms of managing this situation and coming out with some solutions.
Thank you, Joy. Thank you, Joy Chakraborty. Can you hear me?
Yeah, we can hear you.
Thank you to the CAHO fraternity, to Dr. Vijay Agarwal for his kind words. I'm so happy to see my friend Vivek Desai here, and Lallu Joseph. I'm an outlier in this group, more than even Vivek Desai is. And I'll take you through the thought process that one would use on a quality management assignment. The first question I'd ask you is, who is your customer? How much do we understand our customer? Customer in terms of behavior, in terms of demographics, the patient, the family. I'd like to add to this family of customers an even more important customer, the internal customer, the employees. Can you deliver customer satisfaction without employee satisfaction? Fundamental. Your employees are the only asset that appreciate and value. All others depreciate. And yet we use employees as a cost and depreciating assets as an asset. Think about it. We also need to look at society as a customer. They've given us permission to perform here, but are we in any way upsetting their way of life? Could be, example, generation of waste, toxic waste, etc. Create stress. And a fourth customer is Mother Earth. A very patient customer who, when she's had it up to her fill, gives you a coronavirus to help you reevaluate how we should run a hospital. Having said that, the work we do, across silos is called a process. Now, this cross-functional process is where problems occur. Each silo does their part of the work efficiently and throws it over the fence to the next silo. At times, the handshake is not documented. And that's where the chronic problems start. Take, for example, the admissions process. It's a nightmare for most hospitals. The discharge process is so laborious that it impacts capacity utilization of a hospital. Can we streamline, to start with, admissions and discharge? I'll move to the next topic. How do you create a culture for quality? Quality can't be a department. Quality must be in the DNA of every employee. No employee will tell you they do bad quality work. That would be very offensive if you confront it. So you've got to create a sensitization, a culture. Housekeeping practices. Housekeeping practices creates a quality culture without trying to give them the bitter medicine of do quality. It sensitizes people to mistakes, to errors. It's an education. Housekeeping, I'll underline, in the future will be center stage. And Vivek gave a few examples of how housekeeping is going to happen. It improves the image of the organization. It sensitizes the employees, and society find the hospital a responsible entity in the community. Having addressed housekeeping, I would then tiptoe into safety. Safety. Human life is at stake for the patient as well as the employees. What happened? Why safety? Something failed. Why did it fail? Poor quality. Now, the maximum risk comes from some very basics. Clean air, clean water. If your practices for cleaning the ducting for clean air is good, people are safe, patients are safe. But we've had instances where reputed doctors, surgeons have lost their reputation because patients die in the surgery, in the operation. Why? The quality of air was faulty. I won't name the example. I'm sure those who have been in Bombay know whom I'm talking about. The risk associated with some basics like air and water. How many qualities of water do you have in a hospital? Multiple. I'm told there are 5 types of qualities of water. Are we addressing this? Three, I'll move to the next topic I want to cover. When you visit a hospital, it's always crowded. With people waiting for a service, and it's queues, and it's generally very stuffy. We need to apply some industrial engineering methods, such as queuing theory, to make sure that within the space we have, we still have a respectable queuing process. And now with this safe distance bit, it's going to be even more. Queuing theory has benefited banks long ago, airports long ago. The time has come for hospitals. We're queuing up for every service. And my last point I'd like to make is, even if we do everything perfectly, even if our processes are fine, the hatchery for bad quality is supplier quality, outsourced services quality. You may be having the best NABH system, but you may be importing problems. Why does that happen? Because we negotiate based on lowest cost typically. What should we be buying? process capability of the supplier. So if you are clear who your customer is, and you get into the culture issues of housekeeping and safety before you bring in quality. 3, if you rationalize the queuing process at every station. And 4, you look at supplier quality. Believe you me, continuous quality improvement, if you went backwards, the root causes are invariably imported from suppliers. So a supply chain must be seen end to end. Thank you. I'll end here.
Thank you, Mr. Lulla. I think we have spoken and shared our problems in one way, and you have very beautifully has shown a different dimension that how that needs to be handled and managed. And I'm sure you'll be getting a list of issues and we'll be working together, as Dr. Agarwal has mentioned, in terms of getting solution to some of these issues, if it is not 10, at least for 3 to 4 of those challenges. So thank you very much for sharing and enlightening us with this. As all of you know that we have crossed our time limit by close to 30 minutes, and I see around 37 questions are there, out of which maybe 2-3 have been addressed. I think we'll
address those questions, by email. I think.
Yeah, I was about to tell that there is an email ID, office@caho.in. In that you can post all your questions, and a lot of questions I can see in terms of reuse of N95 mask, whether we can use this PPE, what is the kind of policy has been adopted by Apollo, Fortis. So I think we'll be taking those questions by email and posting it to the relevant people, and we can come back to you with the answers in a short time. So we'll not take much
comment before you just are ending. I'm just saying, I in fact forgot that, for example, at this digital health avalanche, I would say, there is a huge issue of cyber security coming up. So in fact, we had a guy, Dr. Sanjay Bhal from the Government of India also, we had a kind of a meeting with him. So we are coming out, CAHO is coming out with a self-assessment toolkit for every hospital to do a cyber security checkup for yourself. And after that, if you find there are things, so this organization called Innovatio Curis we are trying to standardize their rates to help you out for a virtual meeting or for a real meeting. Something we'll try to do that. But first thing is that if you can start using that, and I'll be sending you the copy of that webinar that was conducted, which had very nice information to all because I feel cyber security is being ignored, and it's a huge, huge issue. So I'll just be, sending you that. So,
thank you very much, Dr. Agarwal. Without taking much time, I want to thank all the panelists who were part of this excellent, panel discussion, roundtable. And I see in the chat box, a lot of appreciations have come for all the panelists, and I'm thankful to all of you for sparing your time and joining today and having this excellent discussion. Thanks to all the delegates or so-called digital delegates who have been part of this discussion for last couple of hours. And I'm sure this will continue to happen. This kind of discussion may not be digitally. Soon we'll be meeting also physically when the lockdown and other challenges gets over. And we'll be more than happy to answer your questions. Please post those questions and we'll give it to the relevant people and we'll get the answer and we'll post you back. So with this, once again, I thank all of you and I want to close this today's session. Thank you very much.
Thank you. Thank you, Joy.
Thank you.
Thank you, Joy.